Hello, children of a lesser joint, and welcome to today's version of Jaw Talk. Karen Purchase, a member of our group, asked a question. This question was generated as a result of her finding a picture of the lateral pterygoid muscle and condyle disc assembly, which stated that if the superior head of the lateral pterygoid did not relax, it could cause disc displacement. Karen wanted to know what would cause the lateral pterygoid not to relax, and was it true? Great question. Let's get to the heart of the issue. I'll be answering this over many episodes. I hope you enjoy. First, let me address the anatomy of the lateral pterygoid muscle. The lateral pterygoid muscle is composed predominantly of two heads, a superior one, which is the top one, and a bottom one called the inferior head. There is also the reports of an additional head, making that a third head in 20 to 22% of individuals studied. Notice when I talk about the superior head of the lateral pterygoid, in this diagram, the disc is highlighted in blue and the superior head attaches or inserts into the disc. Besides the disc, in addition to the disc, the superior head also attaches to the condyle, which is the bony part of your jaw joint that moves. The lower head of the lateral pterygoid inserts only into the condyle. And so the upper head is responsible for maintaining control of both the disc and the condyle, whereas the lower head or the inferior head is responsible for movements associated predominantly with the condyle. In 1961, and probably the reports date back prior to this, Kamiyama is generally credited with talking about what's called the reciprocal function of the two heads of the lateral pterygoid muscles. Reciprocal means movement in opposite directions. The superior head, the top one, is responsible for predominantly closing the jaw and backwards movements called retrusion. The inferior head was purported to be active predominantly during forward movements, which included straightforward movements called protrusive, or those which were on a lateral trajectory or sideways movement while going forward. Always, it's associated with opening. The reciprocal function became part of dental treatment protocols. As you can see here, this was taken from Dr. Dawson's book on functional occlusion in 1989, which is how I learned about parts of the functional story here that was built around occlusion and joint position. So already we can see that this is filtered into principles that are taught in dental occlusion and temporomandibular joint dysfunction. In the forward movement, you can see how the superior head is negative. It's reported to be inactive, while the movement as it goes down, as seen by the red arrow in this illustration, is positive. In other words, the inferior head is active. Yet as we move back from an open position, we can see that the superior head now becomes the active muscle, called reciprocal function. These concepts, as they made their way into dental principles, and portions of this have been there for over a decade, related to a condylar position called centric relation. A centric relation has changed many times in terms of its definition. I don't want to really go into this right now, right here. My only point here is to demonstrate that condylar position, based upon muscular function as well as prosthodontic or restorative dental needs, was already a large part of dental principles incorporated into many training programs, including dental education. The most important point I want to make here for Karen and the members of the group were that when they used the principle of centric relation, the position of the jaw joint became a dominant factor in describing the relationship that the teeth would occupy when the jaw joint was ascribed to be in an optimal position, which is at the top of this triangle or apex. Even though this is just diagrammatic, obviously it's made to represent the condylar fossa, the bone against which the condyle will move against and brace against, with a disc in between over here. But notice what happens. If the condyle is prevented from going into position by the teeth now become the scapegoat, and this became the impetus for us to treat this not only as a symptom or sign associated with temporomandibular joint disorders and muscle dysfunction, but it also became the outlet for preventive services, whether or not the patient may or may not have had any symptomatology at all. And of course, based upon the experience of the dentist, based upon his skill and care and how he would choose to exercise his expertise, that would be up to the discretion of the clinician as to whether or not in an asymptomatic individual this would need to be done. Here's the book from 1989, Dr. Dawson's book. As I said, this now became a rationale for treatment that was discussed in many training programs. The Dawson Academy was one of them, the Pankey Institute. It's been talked about by other noted authorities in dentistry over the years, like Dr. Coyce or Dr. Spear. All have had something to say about the role of the position of the joint in relation to the teeth and occlusion. But also for Karen, the most important point here is that what they were talking about was when this joint couldn't go into that optimal position, it placed an onus on the lateral pterygoid muscle complex, which was said to drive this into a hyperactive model. And because the superior head attached to the disk that this became the rationale for how we got disk displacement, and also the rationale which dictated some of the treatment principles that I had learned about in my earlier years. The real question at this point is whether or not any of it, all of it, or part of it is true. You'll have to wait till the next episode to get some more answers. In the meantime, thank you for sharing this episode with me, and please join me again for the next episode when I'll be rocking it out with Jaw Talk.